Welcome to another episode of Let's Talk Small Data with T, where we are passionate about the power of small data in healthcare. I am your host, Tanazia Gonzalez, but you can call me T. Data has certainly changed the game in healthcare. Big data has blown the roof off, but small data, now that's the future. Small data allows us to dive deep into the key insights and take quick, customized action to achieve phenomenal results in performance and quality improvement. Let's explore this today. Thanks so much for joining us. If you have any questions for me or any of my guests, feel free to reach out to me at tgonzalez@eima-inc.com. Enjoy the show. Let's go. Welcome to another episode of Let's Talk Small Data with T, where we explore the power of small data in healthcare. I am your host, Tanazia Gonzalez, and I'm so excited to introduce you to my guests who are joining me for today's discussion. I have two experienced and very passionate individuals joining me to talk about how they are leveraging the power of small data in healthcare, and how they're leveraging the power of small data in their work with young populations. In our earlier talks leading up to the show, we talked about a number of topics, including adolescent health and mental well-being, sexual reproductive health, interventions, psychiatric epidemiology, and small data as formative data. I'm so honored to welcome Dr. Tashuna Albritton and Dr. Deidre Engelin to Let's Talk Small Data podcast. Welcome to the show. Thank you so much for joining me.
Hi, thank you for having me.
Thank you. Dr. Tashuna Albritton is an assistant medical professor at the City University of New York School of Medicine in the Department of Community Health and Social Medicine. Dr. Albritton has extensive training in community-based HIV, STD, behavioral health intervention research, particularly with underrepresented minority, adolescent, and young adult populations in both urban and rural communities. She is interested in using online platforms to promote biomedical HIV prevention methods in high-risk populations. She has a PhD and master's degree in social work. Welcome to the show. Thank you. Next joining us is Dr. Deidre Engelin. Excuse me.
Thank you. I'm very excited to be here.
Thank you. I'm happy to have you here. Dr. Deidre Engelin is an associate professor of psychology in the doctoral clinical psychology program at the City University of New York, with postdoctoral research training in psychiatric epidemiology at Columbia University's Milliman School of Public Health. Dr. Engelin leads several projects and mentors students in her clinical and social epidemiology lab, designed to identify social determinants of psychosis risk in racial and ethnic minoritized populations. She has published several papers focused on race, racism, and psychosis and the stigma of mental health service utilization in Black and Asian populations. She has a PhD and a master's degree in clinical psychology, as well as a bachelor's degree in human development and family studies. Thank you for joining us today. I'm so happy to have you all here. So I guess we can go ahead and take a moment for Dr. Albritton to go ahead and say a few words to spell out that introduction I kind of introduced, and kind of tell us a little bit about yourself, your background, and what are your key passions?
Okay, great. Well, as you mentioned, I'm currently an assistant medical professor at the City University of New York School of Medicine, and I've been on faculty there for the past 6 years.
Okay.
And so broadly, my work is specific to sexual and reproductive health research with adolescent populations. And most of my work has focused on primarily Black adolescents in the US, and also some Latino populations in the US as well. And I guess I kind of began my research interest, I should say, began in the world of kind of HIV and sexually transmitted disease prevention many years ago, like late 90s, my first job out of undergrad was with a community-based HIV prevention research for Black women who are also substance abusers. And so in my time of working on that research team, I really felt like this was a passion for me. However, I knew that there was a younger population that needed to be reached. And so, and trying to kind of figure out my life and my career, I actually ended up going on to actually get my my master's in social work. And I worked clinically as a social worker for maybe like 5.5 years before going back to get my PhD in social work. And let me just clarify for the audience, a lot of times when people think of social work, they think of clinical practice or direct services with different populations. But my program was specific to research and how you develop interventions for different populations. So because I knew I had an interest in a younger population, specifically adolescents. So all of my doctoral training was around adolescent, understanding adolescent behavior, specifically risk and protective behaviors among adolescents. And learning how to methodologically, scientifically understand behaviors, develop behavioral interventions to intervene at risk behaviors, and to implement them in the community or with the population and test their efficacy or effectiveness, right? And so that's my kind of background training. After I left my PhD program, I went and did a postdoctoral fellowship at the Yale University Center for Interdisciplinary Research on AIDS. So I was there for 3 years, still doing HIV prevention research with adolescent populations. So I would say, when I was doing my doctoral work, I was actually, I'm from North Carolina, I'm a native Southerner. And so I was also in North Carolina getting my PhD. So at the time, that work was primarily with rural populations. And that was really exciting to me because I grew up in a very rural area, extremely rural. And I was actually working in counties that were surrounding where I'd actually grown up, because the HIV, gonorrhea, chlamydia cases were extremely high prevalence rates in those areas. And so a lot of the work that I was doing with mentors were basically in the back door of the community where I grew up. And so for me, the community aspect of really doing kind of public health or prevention work just kind of, it really invigorated me even the more, because I felt like I was working with communities that I could relate to, and the need was there. So fast forward, coming, doing the work at Yale as a postdoctoral fellow, that's when I began to do my work in more urban settings. Prior to, I had no kind of intervention, prevention, research experience in urban settings. And so I wanted to be able to marry those two professionally. And when I started my academic career, to have the ability to understand how to implement prevention interventions in rural as well as urban settings. And so I've been fortunate to be able to kind of adopt, that into my work. And so I think that's kind of me in a nutshell in terms of the background.
Wonderful, thank you. I mean, I would love to hear maybe later on in the show some success stories that you're able to share with those prevention interventions, because I don't know if I share this with you, but I too, my career really blew up with HIV/AIDS care. I was a director of CQI during interventions and performance improvement in New York City, St. Luke's Roosevelt Hospital Center. And at the time, it was the largest HIV/AIDS care center in the state. We were working with Johns Hopkins and receiving funding from Ryan White and Johns Hopkins and a bunch of other outside grants and everything. And it was just, I don't want to say fun, but it was fun to be able to produce the data and the tools that the clinical team needed in order to drive the improvement of the interventions that they were putting in place, particularly with the young adolescent population we had in prevention, and also working with individuals who acquired HIV through behavior versus being born with it. So working with those two populations and just, understanding the different factors that you have to take into account in terms of the way they behaved and the way they lived their lives. And we had some really positive impact there. So thank you for that. Dr. Engelin, would you like to give us a little introduction into you and your background, your passions, and some of the work that you're working on? And then we'll later on dive a little deeper into maybe a project or two that the two of you would like to talk about and introduce.
Sounds great. I just want to say it's Dr. Albritton is definitely a Southern girl, and it's been wonderful working with her. I'm a New Yorker, and sort of grew up in Long Island, and I went straight from Cornell bachelor's, went right into my PhD at Fordham, and so I'm clinical psych. So you have to do a lot of clinical training as well as research. Yeah, and it's just so interesting, sort of hearing Tashuna's path, because it was on clinical internship at Emory University School of Medicine, where I really said, oh, wait, no, I got to research this. I got to do more research. And so basically, I still remember the patient that I shared with a psychiatric resident, Dr. Jabu. And he came in, he clearly had some psychosis, but there was a lot of emotional lability. He had lots of thoughts about, at the time I had locks, and he had all these kind of, but he was, I knew there was some psychosis, but it felt like there was also like an emotional component going on. And he came in via police, right? And unfortunately, you don't get a lot of collaborative information when that happens. But I would see this pattern, I would see this pattern, and, prominent, attendings would say, oh, that's schizophrenia. Wow. He's got schizophrenia. And I was like, but he's got so much there's an emotional piece going on here, right? And so, long story short, a lot of different antipsychotic meds just not working, not really putting a dent in his level of psychosis. And he still seemed very manic, right? And so eventually, after months, because I was sort of advocating for maybe he has like a bipolar, or maybe he has something different. But the hesitancy to be open to that for this young Black man, it was something that I saw again and again. And then I looked at the literature and I realized this was a pattern. Young Black man comes in via police to the psychiatric ER and is more likely to be labeled schizophrenia, and then given more severe, more strong doses of medication. And so finally they decided to, sort of give him something different that affects the mood. And I tell you, he just cleared up, where he was lucid, he was funny, he was relatable, he was just the sweetest guy. And before that, he was so ill. And so it really, really impacted my passion, if you will, right? If you asked about passion, to get it better, to do better by young Black men who come in with all of this adversity and then have psychiatric challenges, but are labeled, right? And then not given adequate treatment quickly enough. And so I decided to do a postdoc at that point at Columbia. And I just delved into research, even though I still, I got my clinical training. And I've been interested in that ever since, really. And I think my interest has evolved, and I've been really interested more in what are these things that happen during early childhood in the environment, in the neighborhood, connected to structural racism, that really can set a young person more likely of color, more likely to have psychosis and other related mental health challenges. And so I'm sort of excited to do that work. And I'm honestly really passionate about doing that work, because I feel like there could be some prevention there.
Totally.
You could actually do something before it's the patient that I worked with on internship, right? How do we do things in the environment before that happens?
Thank you for that. As you're saying that, it's bringing my mind to what just happened in Texas. And I just want to take a small moment here, small moment of silence, to honor those victims. Thank you. Yeah, and what is it we could have done? What are the red flags? What could have been done and where? Like I've been hearing, on my guests, I ask, okay, we see there's an issue. There's something we need to improve here. We need to work. Okay, where do we start? And a lot of them speak to education in the schools, obviously with the family also, but to support the family, where can we integrate that? Where can we weave that in? And how do we weave it in so that we catch stuff and we recognize stuff before it gets to this young man walking into an elementary school and killing 19 people? How can we, and this has been happening a lot. I mean, we're in a time where we're having mass shootings. So the three of us are sitting in New York City, in New York here in the East Coast, but this podcast episode will be viewed in many other countries. But right now we are experiencing these mass shootings. And really, folks are talking about gun laws, but we need to do more talking about how do we get there first, mentally, emotionally here, and how do we help? So thank you for the work that you do, the two of you. I'm really, really impressed by your work, and thank you for sharing your passion and your background. And thank you for putting in the time, in the years. I know it wasn't overnight to get where you are. I really admire the two of you, and really aspire to be like you, and having the impact that you have on individuals. My passion is in data, especially in small data. I've been in healthcare my whole career, which is over close to 25 years. And I really love diving into data, to really dive into the individual and really understand, where are we with this individual? What is it that we need to improve? Okay, here's where we need to get to, and let's track and monitor. Put in place some kind of intervention that's evidence-based to get us to this destination over here, into a better place to improve that individual's life, that individual, that group, that population, the world, So in the work that you all are doing, I understand you're working closely with young individuals or a young population. Is there a specific study or project that you'd like to talk about and kind of dive into, to really give us an example of how you're leveraging the power of small data to meet your goals?
Yeah. Well, Deidre and I are working on a project together. Well, let me just say that, the project we're done with data collection, but we're still in the process of analyzing data.
Okay.
The project. So this is a project where we are using both quantitative and qualitative methods to collect data from adolescents and their parents, specific to how they're coping with the coronavirus pandemic.
Okay.
And these are families that identify as Black and Latino in the Bronx, New York area. And when we were putting together, when we were actually writing the grant proposal for the project, we knew kind of the pot of money that we were working with, right? So the pot of money was small, so we couldn't have like super ambitious aims for the project. So they had to be, reasonable within the funding mechanism that we were doing. In addition to kind of that, the quantitative piece, which is that more of the survey related data that kids and their parents would receive, it's also the qualitative data collection, which in this case, we decided to use a qualitative method called Photovoice.
Photovoice.
And so Photovoice is exactly how it sounds.
Okay.
Is that you're a participant in the study, as a researcher, or in some cases, the researcher have members of that group who are participants, decide on a theme or a topic in which they would like to take a photo. In some cases, the researcher will give a topic or a focus to the participants and say, I would like you to take a picture of, for you, what represents kind of the most stressful time, in your life. Or during, in this case, because this was specific to coping in the pandemic, specific to your time and your experience throughout this coronavirus pandemic, right? And so they would take photos, and then we would meet back as a group virtually because we couldn't meet together at that time. Small group, like we had a series of meetings, and so in each group they were, maybe like 4 parents in their own group and 4 youth in their own group, and they would actually discuss their photos. And so they would pull the photos up on the screen. They had their instructions in advance, like this is your topic, and we would see visually their photo, and then they would give voice. So Photovoice, they would give voice to what the picture that they took, right? Okay. And so the Photovoice methodology is grounded in empowerment theory as well as social justice frameworks. And so I think for myself, and perhaps, Deidre can speak to this as well, is that most of our work is done in traditionally or historically underserved communities. And so in these particular communities, I think we were both very mindful of the type of methodology that we use and the framework that we use as we're thinking about research, that actually, when we are collecting data, that actually gives our participants a voice beyond just clicking the next question on a survey.
Wow.
Yeah.
So
and just
I'll
to add,
take over, yeah.
Powerful.
just to add to that, T, like we worked with amazing community activist, organizer, who's in the Bronx, with her sort of boots on the ground and with the youth. And so we wanted to really access and work with youth who are really from the community that probably are not necessarily represented in the large epidemiological studies that I've done in the past. They're not an N in those studies. And so we really wanted to accentuate that aspect. And so we worked with someone from the community who works in the community. I think that was an important piece, especially in terms of small data. If we really want to get a sense of how is this collective trauma that's been happening, like how is this really, how are folks coping? How are they doing well? How are they struggling? But it allowed us to see really visually what's happening represented, but it stimulated such interesting discussions among these adolescents and their parents, especially. It was sometimes healing spaces, I would say, for some of the parents. Absolutely. Just to be able to talk with each other, even if it was even though it was on Zoom, it was sort of a moment where they could be like, oh yeah, I lost my job, and how are you managing? One person had a GoFundMe that they were using, in terms of, and it was just like a very revealing. So I really, that's why I was so happy to do this podcast, because this small data to me And I'm, again, with a psych epi background, I'm used to large
Yeah.
data, right? And so
Yes.
I'm sort of really invigorated by just how much I feel like me and my doctoral students, especially, because they were a big part of the work, running the groups. It really impacted them. They're clinicians in training, and they got to really work with folks in a research capacity from the community, and they're like, it's shaping their dissertations.
Right.
You know, it's shaping their, even when they think about the clinical work they're doing, you know, it's making them think differently. And so I really believe in the power of small data, especially when you go into the community and work with folks from the community to access that data.
I love that. It's so beautiful, guys. As you were explaining, you know, the groups coming together, I was just getting chills.
Formative data is a research term that we use like to describe or to think about our data as helping to inform the next phase of a larger study. And so in that case, our formative data is usually that small data, right? And so that small data, when we analyze that small data and we kind of see themes that are emerging, trends, because we can actually go into a study thinking one thing based on what we know in the literature, based on kind of what's happening like in real time. But when we actually get that small data and we hear the voices of the participants involved, in addition to the quantitative data, the numbers, we're able to really take a step back from the table as scientists and say, we need to probably think about emphasizing this component over this component, which was our original thought. So it helps us to shift where there is a need. And the thing I think about for folks who do community, all of my work is community-based. So I consider myself a community-based researcher. I'm not a person who deals with large epidemiological data, right? And so, I mean, which is great because Deidre and I can play off each other. She's the big data person. I am like the smaller data person. So we make a beautiful marriage, right?
Very beautiful.
Take a village.
As researchers, and so we really use small formative data to inform all aspects of the next phase of a larger study. And so it can determine, okay, a theory, how we frame the overall. It can also determine the next phase of kind of methods for data collection. It could help us decide what's the best way to implement. We thought that we could do this with teenagers, but actually we probably need to do this in grade school kids. I mean, it gives so much information, which is why formative data is so important before you jump into these kind of large, what we call large scale, whether studies, particularly if you are, I'm trained as an interventionist, right? And so for some of my perspective, it is not wise to leap into, and I probably would not get any funding to leap into a large scale study that you're in, or the number of people that you would want to collect from, it's huge, right? And so I would have to prove to my funders that I could, the rationale for it, that we can actually collect similar data on a smaller scale. So the formative data from a research perspective is very important as we think about scaling up projects.
It reminds me of my CQI days, or continuous quality improvement days at the clinic, where we were following IHI's, or the Institute for Healthcare Improvement's model for improvement, the Plan, Do, Study, Act, which was all about taking small tests of change. So taking small bites to see how that impacts or affects, your end goal before you roll it out to the overall. So I totally understand that and can appreciate that. Yeah, thank you. Did you want to say something, Dr. Englin?
Yeah, no, I was just going to sort of give maybe like an example, just
Yeah.
in terms of how this, just one kind of small example in terms of how the small data is formative and revealing.
Mhm.
You going into it with hypotheses, and Tashuna and I were thinking, we're all, obviously thinking about the elderly folks who've passed and during COVID, thinking about, the family members, but like, what about how are the youth really being impacted by COVID? And at the time when we started the study, gosh, I guess a couple years ago, there wasn't enough on that. And so now we have this really interesting data about how the youth, the level of stress they feel, and how it compares to their parents. And so
Mhm.
if you
Mhm.
looked at it quantitatively, you would say, oh, both have some stress. Okay, right? But if you look at it qualitatively, the things that are stressing out the youth are very different in a
Mhm.
lot of ways from the things that are stressing out the parents.
Yeah.
And so if you were to do a sort of next step small intervention, you would really want to tailor it to be adequately, so to adequately address the
Mhm.
types of stressors, like in terms of like the high school students and thinking about their grades in the next step, or like missing school, or the
Mhm.
degree to which, if you're living in a community where there's not as many resources, not being able to work
Yeah.
after school, that was actually affecting a lot of the youth as well.
Yeah. Yeah.
But and for parents, obviously they were thinking about similar things you could imagine in terms of loss, et cetera, around COVID, and just
Yeah.
like surviving. But there was something about the school and what's my future going to be, and things like that that came up that
Yeah.
felt, I don't know, we would get that from a big data project. We wouldn't know that level of nuance. And
Yeah.
so it would be important to really target that and address that if you're going to try to help youth cope with the uncertainty of what's next,
Totally.
So I mean,
Yeah.
that's just like a small example of just what we saw
No, no.
differences between the parents and the youth, even though quantitatively you might think, oh, both have high stress.
Yeah, but what does
No.
it mean, right?
Right.
Right. Like, and then once we have it, once we understand it, now what? What do we do?
Right.
And thank you for that. Yeah, no, I've told you before, I have 3 young boys, and I remember when school went virtual, I could see the impact of not being able to have that social interaction with their friends at school. I saw that firsthand. And I'm like, okay. I was constantly on top of them, just making sure we're talking to them and making way for open communication, and just making sure they could come to us, the parents, to just say, I'm stressed out. I can't talk to so-and-so today. I can't do this and that. And this has changed. Boom, like that. How do I deal with that? So, but not every person had the same level of support, as
Oh,
we know, right?
Right.
Um,
absolutely.
so yeah, no, thank you for that. So with the Photo Voice project, and I believe I said Photo Boys. I want to correct myself now. It's Photo Voice,
Mhm.
which I love that. Um, do we know what the outcomes of that were on some of the participants? I'm talking about the youth. Like, when did this take place? The Photo Voice?
Yeah, so we collected data 2020 through 2021.
Okay.
Yeah.
So I'm wondering, like, what was the long-term, not long-term, but impact, maybe a year out from that, or 6 months with those individuals?
Yeah.
What positive impacts, or impacts in general, did they experience after going through that project?
Yeah. So I think um in the case where we're collecting formative data,
Mhm.
because we don't collect data over time,
Mm,
it's hard to see if there would be changes over measures over time.
mhm,
So we would consider that like more of a longitudinal study.
mhm.
This
Okay,
was not a
okay,
longitudinal study, right?
okay.
And also this study was not an intervention.
Okay.
And so usually if we're interjecting an intervention or intervening on some level,
Mhm.
right? because you actually can use Photovoice as a form of therapy. Some people may call it art therapy, but we use it as just a form of as a different way of collecting data, right? And so, because this project did not introduce an intervention per se, it would be difficult for us to kind of see any impact from our particular study. Now, if we were to collect, measures from base time, meaning before we did any kind of engagement with the parents and the kids with Photovoice, and then maybe collected data from them, 6 months out and 12
Pre and
months
post.
out, we could maybe see some differences in responses, even without this being an intervention, because people change over time.
Yes.
Right?
Yeah.
And so, and remember, we're having at some point, the research team we're in dialogue with them. And so, as Deidre said, like in some cases, this was therapeutic for people who like normally either couldn't afford a therapist or would not really, I guess, make themselves as vulnerable. And so, I mean, we were talking amongst ourselves like, wow, I wish that this was a project where we could continue to collect data over time, because we felt for sure that we would start to see some different responses on some of the measures that we were assessing, right?
Yeah.
So, but you bring up a beautiful point, which is like, our next step hopefully will be like, we would, expand the project to be able to collect data over time to kind of see what it was
thinking off the cuff. First of all, before we get too much further, how would you define an intervention? Just for some folks who are listening who may not know.
Yeah, sure. So an intervention is usually a program of some type. So in some cases, it's developing educational modules that can be implemented in person at different community-based organizations or even in hospital settings, right? And so it's kind of educational pieces, or it could be a one-time educational. And then, so you basically test the person at baseline before they get any kind of program or exposed to anything differently. And then after they're exposed, you would test them afterwards to see if the intervention made a difference.
Right.
And I mean, some interventions could be you train your staff, when someone comes into a clinic or, whatever organization or in a school setting, your staff is trained to have, deliver this information to a child, to a parent, to a, family unit. And then screen afterwards to kind of see if there's some kind of response. So an intervention can look differently depending on setting, depending on the population, depending on the age. It could be verbal, it could be written.
Okay.
But it really is to, if an issue is identified, the intervention is to see if you can shift it to have, better positive outcomes.
Make some movement on that issue. Thank you for that. I'm pretty sure that there are so many ripple effects from that Photovoice project that we may never be able to measure or see, but it's really impacting the lives of those around the individuals. Then they're passing and paying it forward, what they've learned, and then they're paying it forward. I mean, the ripple effects are huge, I can imagine. So it's a beautiful project. Hopefully you guys, ladies, excuse me, would be able to continue that and maybe do another round or expand it a little bit.
Yeah. No, because I think anecdotally, even going through, because it's not like it's one session. It's a few. Meeting with a small group, a few sessions. And so even that meeting 3 times, especially for, I would say, the parents, to be honest.
Yeah.
There were tears.
That was an unintended.
I'm definitely involved in another Photovoice actually project that it's really focused on specifically on the clinical population and Black people specifically. It's like sort of a really targeting anti-Black racism in how that, sort of how that shows up in the neighborhood, in the social environment, for
Mhm.
young Black folks with early psychosis. So
Okay.
they're sort of early in a way where we could really sort of shape the trajectory to be much better than what you sort of think about when you think about what's the trajectory of someone with schizophrenia or clinical
Mm.
psychosis.
Okay.
And so this has been, it's hard to recruit, especially during COVID, but we've had a few participants, sort of small data, but my goodness, big insights in terms of how triggers exist for folks with more significant mental health challenges in the
Mm.
neighborhood. And so, for example, one of the participants, she took a picture, because again, giving in pictures of a sign,
Mhm.
regular parking sign, no stopping, 9 to 10, da da da.
Mhm.
And then there was something underneath, someone, I guess, was trying to be proactive. Stop killing Black people. Police, stop killing Black people. It was just right with the parking sign. And she talked so eloquently about how, for someone who did this, they probably felt like they were being like conscious and like, social justice, right?
Mhm. Mhm.
But it was a reminder to her that we need a sign, right? We need a sign to remind us to stop killing Black people. And so it like made her have to sort of go into a thinking process as
Yeah.
she walked past this sign on her way to work. And it's just sort of like, it just was like a really small, very precise, specific
Mhm.
example,
Mhm.
but it really highlighted how the intentions that might be that exist in terms of people's for social justice, right? For the
Right.
person who's targeted by that, the person who's dealing with that might be received very differently. It might
Mhm.
be a reminder that's painful, and to have to see that every day on the parking sign.
Mm.
And so it just stimulated this discussion. And so this is just another project with a clinical population that
Okay.
I'm working
Okay.
with. And the small data is small, but so revealing about how that can
Small
trigger.
data, big impact. Yeah,
Mhm.
big insights. Thank you for sharing that. No, I mean, we could have probably about 5, 6, 10 more shows to dive into that. Um, so I appreciate you letting us know about that. In terms of the younger populations, the adolescents, any other projects that you're working on right now or on the roadmap to collect data, dive into the small data, and do some, I see you shaking your head, Dr. Albritton.
Yeah. So I have a Photovoice project also
Okay.
that's starting in the rural South. And so I have worked really hard trying to connect with organizations
Mhm.
because I'm now geographically located in the Northeast. And
Okay.
um, so again, it goes back to what Deidre was saying earlier. It's so important to connect with folks who are living in that community because we may share a skin complexion does not mean that I'm a member of your community, right?
Mhm.
And
Mhm.
so, it's about building a relationship so you can actually work with the populations, that um, um, are facing higher level of disparities
Mhm.
health-wise than other populations. And we know that from the data, we know that from CDC data, we know that
Right.
from National Statistical Center data.
Mhm.
So this is a sexual reproductive health project that I'm going to be working on. Again, like I do a lot of dyadic data. And what I mean by dyadic data or dyadic data collection is I collect data in pairs usually. So it can be parent child, it can be romantic couples,
Okay.
it could be, peers, friends. And so in this case, I'm doing a project specifically with mothers and daughters
Okay.
of Black women. And I'm very interested, again, we know that the family unit is very important, that that parent behavior, they model for their children, right? The parents
Mhm.
are the first teachers usually that kids or children
Yeah.
interact with.
Mhm.
And so I'm very interested in understanding the experience that Black women have in gynecological services, or just overall kind of primary care services specific to sexual reproductive health, and how those experiences influence their teenage daughters' experiences.
Wow.
And so, because, you know, if a mother has a poor experience in the healthcare setting, in most cases, mothers will warn their daughters.
Exactly. Yeah.
They will say, you don't want to see this person. Make sure that when they ask you this question, don't respond this way, as a protective factor for their young daughter, right? And so, or does it push Black females out of sexual reproductive care seeking altogether because of poor experiences? So I'm really interested in looking at kind of their shared experiences, and particularly how the teenage daughters see a way forward in their own sexual reproductive health.
Interesting. And the word empowered came to mind, like really empower these young ladies. I love that. I would love to hear more about that once it's, you know, further along, and love to have you back on the show to kind of dive into some of the data and kind of the use cases and the outcomes and, you know, whatever else you'd like to present. So, I mean, I could talk to you forever. I love it. I love the work you're doing. Thank you for the work that you're doing. So needed, and really serving us all. The community, Black community on planet Earth, I'm talking about all communities on planet Earth. And, you know, with that, is there any specific call to action you'd like to put out there for folks to take action on? Dr. Albritton, I know you were saying you were trying to connect with certain organizations. You know, this podcast may come across the table of some other organizations that may want to connect with you. So any specific call to action? I'm talking to both of you now. And also tell us, how can we get in touch with you should folks want to reach out? Dr. Albritton, you can go first.
Okay. I would say the call to action for me is that I think what we see is that even though we work with, I work with small data, particularly, and this kind of go up from there, is that I think a lot of our work as researchers has to get to a point where we can really influence policy, whether within local organizations, local government, state government, or even on the national level. Because there's a lot of the suffering that I see with kids, with families, with parents, is an unrealistic program policy that does not really meet, I guess, the true needs of children, of mothers, of fathers, right? And so I think that what some of our small data does is really illuminates how at some point we're missing the mark. Because even though I'm trained as a behavioral interventionist, all of the ills that we see are not based on individual behaviors. So it speaks to programs that are not well aligned to meet their local communities in some cases. And it speaks a lot to policies, and particularly going back to the fact that Deidre and I usually work with historically underserved, lower income, just all the, you know, the disparities that you can think of, like communities. It's just I've seen, and maybe I just kind of have a heightened insight to that because I, my clinical, I was a clinical social worker for many years. And part of the reason why I kind of moved on is because I felt like we were putting a Band-Aid on festering sores. And a lot of it is because I was dealing with policies that were not effective, that was not going to make a significant change in the lives of those who were suffering the most. And that was so frustrating for me. And I still see it, but I'm just doing something different,
So a
right?
lot of systemic issues
A
that
lot of
go unaddressed.
systemic issues that I think that researchers, scientists, particularly when we work directly with communities, how we can just kind of translate that. And some people are more effective at having their science translate and to get a certain audience than others.
Okay.
Right. And so, but so that would be my call to action for anyone who would watch this recording, and whether they're scientists or whatever they do, that we really think critically about engaging or trying to make those connections. Because I think sometimes as researchers, like I'm not I'm civically active, but I'm not a political person.
Right.
And so you kind of have to know the right moves. And I'm hopeful and optimistic that when those marriages really happen from a research and policy level, that we can see policies move in a way that is going to be very helpful to communities of all backgrounds, not just
right. Thank you for that. So if folks want to contact you, what's the best way to get in touch with you?
My email is T as in Tom, A as in Apple, L as in Larry, B as in boy, R-I, T as in Tom, T as in Tom, O-N as in Nancy at med.C as in cat, UNY.edu.
Wow.
So, long name. But yeah. Or they could just Google my name and I should.
Yeah, I mean, for those listening, for those listening, I'd like to give my guests the opportunity to just say, how they prefer to be contacted, but in the notes of the show, you will have full bios and links to their LinkedIn, as well as their email addresses and other modes that they provide for where you can get in touch with them. But thank you for that. Dr. Anglin, what would you say is a call to action, and what's your preferred way for folks to get in touch with you?
Well, call to action is everything Tashuna said.
Ditto. Yeah.
But yeah, no, I feel just that systems need to change and priorities need to change. And so where we put the resources, who is investable, so to speak, well, that needs to change. Are we prioritizing the Black women who are, dying disproportionately in terms of reproductive issues and trying to have a baby? Like, is discrimination a priority in terms of, targeting the systems that increase the likelihood someone's going to experience discrimination day to day, as well as major discriminatory events? And so it's like, for me, the priorities and the systems really need to change and focus on not the majority necessarily to the same degree, but like build up and emphasize what do minoritized populations need. And I mean that in a very broadly, and so as a person who identifies, as heterosexual, cisgendered woman, I'm not walking around thinking about like how I'm perceived in terms of like my gender because I'm maybe transgender, right? Like, so that those kinds of the most minoritized, even among the minoritized, like how do we prioritize those needs, and in terms of our institutions and the programs we develop and and so that's really, I think our call to action is to think about, even if you're in social justice movements, we're prioritizing the most privileged in those movements, right? Who's my, and so how do we really keep those voices, emphasized and at the table?
Powerful stuff. And what's the best way to get in touch with you?
I'm on Twitter at Deidre Engelin. And so you can always message me there and sort of check me out there. And email is denglin at ccny.cuny.edu.
Awesome. Thank you. Yeah. Once again, I'll have all of the contact information in the notes of the show. I would love to have you ladies back on and even participate in a panel discussion, kind of spelling out with some other folks that I've connected with in my travels in this podcast world, because many folks are saying the same things, like coming together. And I'm always saying, okay, now we know the what, now it's the how, and the how and the where. And it's not an easy job, but if we're all coming together as the village I keep talking about, takes a village, come together, shine some light on it, and start picking it apart, we're getting a little closer. So thank you so much for joining me for the talk. We have come to the end of the time, and I'm so appreciative of your time today and your passion, your heart, all your hard work, your brilliance. Thank you so much for the work that you do. I really, really grateful for you, appreciate you. And I'm sure there are a lot of people out there that feel the same. So I'm going to.
Thank you for having us.
Thank you.
Thank you for having us.
Thank you. And shout out to Kiosha Bond, Dr. Kiosha Bond, who was a previous guest on the podcast talking about the sexual health equity of Black females. Thank you for connecting us so that we can have this discussion today. I hope you enjoyed the show as much as I did. To subscribe to the podcast, you can find us on Spotify, iHeartRadio, TuneIn, and look up Let's Talk Small Data with T, no apostrophe. You can also visit www.eima-inc.com and click on Let's Talk Small Data with T to learn more about the podcast and get access to previous episodes. If you would like to be on the show, feel free to reach out to me directly at tgonzalez@eima-inc.com. And this brings us to the end of the program. I want to say, have a wonderful day. And remember, unleash the power of your small data. It's your most powerful and strategic asset. See you next time. This episode is brought to you by Effective Information Management Assistance, specializing in healthcare small data and offering expertise that goes beyond technology. Visit www.eima-inc.com to learn more about Emma and the podcast, Let's Talk Small Data with T.